Hi, my name is Dr. DJ Heusler, and this is part 1 of the corneal disease module. So in this module, we're going to be talking about the anatomy of the cornea, diagnostics, pharmacology, traumatic superficial ulcers, and ulcers secondary to eyelid disease. So with the cornea, we're going to be talking about the epithelium, the stroma, Descemet's membrane, as well as the endothelium. The entire cornea is about 0.5 to 0.6 millimeters thick. So the cornea supports the internal contents of the eye, it refracts light, and it transmits light. The aqueous humor and tears supply its nourishment. It's an avascular structure, and it's typically less than 1 millimeter thick. The anterior epithelium is about 25 to 40 micrometers thick. It's composed of 2 to 3 layers of non-keratinized stratified squamous epithelium. It has a single layer of basal cells and 2 to 3 layers of wing cells. The stroma comprises about 90% of the thickness of the cornea. Stroma consists of keratocytes, which possess crystallins, which are believed to facilitate transparency, and can transform into myofibroblasts during deep corneal injury. This forms scar tissue and loses transparency. There are collagen fibers in the stroma. These are broad belts called lamellae that run parallel to the corneal surface. There are nerves within the stroma, as well as glycosaminoglycans. These glycosaminoglycans consist of keratin sulfate, chondroitin sulfate, and dermatin sulfate. Innervation to the cornea is provided by branches of the trigeminal nerve. They enter the midstromal region circumferentially at the limbus. They course radially to the central cornea in the anterior stroma, and there are free nerve endings extending to the epithelium. Brachycephalics have less nerve fiber density than mesocephalics, and dolichocephalics are more sensitive and more painful. This could be a contributing factor for less ulcer development for dolichocephalics. And diabetics have reduced corneal sensitivity. Outside of diabetic cataracts, diabetics have decreased corneal sensation, increased risk of corneal ulcers, and increased risk of infiltrated corneal ulcers. They have increased risk of fungal keratitis and an increased risk of keratoconjunctivitis sicca. Descemet's membrane is a basement membrane of the posterior endothelium, and it thickens as the animal ages. The endothelium is a single layer of flattened cells. It is possibly regenerative in younger animals, but it is non-regenerative in older animals. The endothelium has a density of 3,600 cells per square millimeter in dogs less than 1 year old. As the animal ages, they will lose greater than 50% of these cells. Other cells become pleomorphic at this time, typically less than 2,100 cells per square millimeter in older dogs. The endothelium has sodium-potassium ATPase pumps which actively pump fluid out of the cornea to keep the cornea relatively dehydrated at about 75 to 85% water. The endothelium regulates hydration of the corneal stromal collagen, which provides mechanical strength to the cornea. Endothelial degeneration or endothelial dystrophy. Dystrophy is more prevalent in Boston Terriers, Chihuahuas, and Dachshunds. And in these photos, you can see the increased corneal edema that has been caused by endothelial dystrophy. This is a progressive disease and can result in blindness, corneal bullae, and corneal ulcers. The peripheral cornea is thicker than the central cornea. And there's a decrease in corneal thickness until approximately 6 weeks of age, then it increases until the dog is about 30 weeks of age. So when we start to look at corneal ulcers, determining the etiology of an ulcer is incredibly important. Is it traumatic? Is there a foreign body? Is there an eyelid abnormality? Is there a tear film disorder? Is it indolent? Is it infected? Is there exposure? So our corneal diagnostic tools include a Finoff transilluminator in order to be able to shine a focal light source into the patient's eyes and look for any abnormalities. We have Schirmer tear testing. Schirmer tear testing should be greater than 20 millimeters per minute. It is not uncommon for us to find Schirmer tear tests of less than 15 millimeters per minute on routine examinations with no clinical signs. Keratoconjunctivitis sicca is a commonly underdiagnosed cause of corneal ulceration in dogs. We should be using fluorescein stain. This can help to identify and locate the corneal ulcer that you are looking for. Fluorescein stain can help to identify corneal ruptures and aqueous leakage via a Seidel test. In veterinary ophthalmology, the workhorse of the cornea is typically a slit lamp. We understand that not everybody has one of these if you're not an ophthalmologist. The slit lamp allows us to look at the different layers of the cornea, the iris, the anterior chamber, the lens, and the anterior surface of the vitreous. The slit lamp provides 10 times or 16 times the magnification, examines depth of corneal ulcers, identifies corneal infiltrate, and can identify keratotic precipitates. It identifies aqueous flare, identifies the epithelium, the stroma, Descemet's membrane, and the endothelium. It allows usage of a light source to identify lesions not easily seen with the naked eye, and it provides a cobalt blue light to highlight fluorescein stain and corneal ulcers. Also included in corneal diagnostic tools are a cyto brush in order to obtain cytology, as well as culturettes to obtain corneal cultures. As we get older, we're not going to be able to see as well up close, so in practice, you should probably invest in a pair of good loupes in order to magnify and light up different lesions. They're very helpful. My practice is a lot easier when I use my loupes, especially as my own eyes get older. So let's start talking about some pharmacology and how it relates to the cornea. Triple antibiotic solution is composed of neomycin, polymyxin, and gramicidin. Neomycin is typically for superficial corneal ulcerations, and it does not penetrate intact epithelium. It targets gram-positives and gram-negatives, such as Staph intermedius and Pseudomonas, and beta-hemolytic strep is highly resistant. With polymyxin, this targets gram-negatives, such as Pseudomonas, and penetration through intact epithelium is poor. Gramicidin targets gram-positives, and it can be substituted for bacitracin when used in an ointment. Ofloxacin is a second-generation fluoroquinolone. Ofloxacin will target gram-positives and gram-negatives, such as Pseudomonas, Staphylococcus, and Streptococcus. As well, ofloxacin has the benefit of being able to penetrate through the intact epithelium, which can reach levels even within the anterior chamber. Ofloxacin is more effective than ciprofloxacin. We do have some concerns that there is some resistance that is increasing with this medication, and we should not be using this for non-vision threatening ocular abnormalities, such as conjunctivitis, because we do have to worry about resistance increasing with such a good medication such as ofloxacin. Another antibiotic that we can use with corneal ulceration is cefazolin. It's a first-generation cephalosporin with a concentration of 50 milligrams per milliliter. Cefazolin is a broad spectrum against gram-positives and gram-negatives, such as Staphylococcus, Streptococcus, E. coli, and Proteus, and cefazolin is not effective against Pseudomonas. Tobramycin is an antibiotic that is composed of Oxytetracycline as well as polymyxin B. Oxytetracycline is short-acting. It's broad spectrum, but the clinical relevance is fairly narrow regarding oxytetracycline. However, oxytetracycline does inhibit MMPs, which are inflammatory mediators. It does slow down the melting process of melting corneal ulcers, and oxytetracycline speeds epithelial migration for healing, especially in indolent ulcers. Tobramycin is another antibiotic that we use in clinical practice, and it primarily targets Pseudomonas. It has a poor spectrum of activity, with only really being able to target gram-negatives. It does not penetrate well into the cornea. However, the penetration does increase if there is inflammation present. Resistance is increasing for tobramycin, and it seems to be a poor choice as a primary antibiotic. Gentamicin targets Pseudomonas as well, has a poor spectrum of activity as it also only targets gram-negatives, and gentamicin also does not penetrate well into the cornea. However, gentamicin may achieve bactericidal concentrations for all Pseudomonas strains. Resistance is increasing for gentamicin and is therefore a poor choice in a primary antibiotic. This hyaluronic acid does not have any antibiotic properties. It's a poor choice to use as a solitary medication for corneal ulcers. It's an excellent choice to use in addition to antibiotics, as this can speed healing. It's an excellent choice to use in lag ophthalmic breeds and excellent to use as a tear supplement in cases of KCS, or keratoconjunctivitis sicca. In a recent study by Hindley et al. Looking at bacterial isolates and antimicrobial susceptibility in Australia, they found that beta hemolytic streptococcus, Pseudomonas, and Staphylococcus were the most commonly isolated. Beta hemolytic strep was resistant to Neomycin, polymyxin B, gentamicin, and greater than 80% resistant to ciprofloxacin. It's susceptible to chloramphenicol and cephalexin. Pseudomonas was resistant to chloramphenicol and cephalexin, and Pseudomonas was susceptible to ciprofloxacin, polymyxin B, and gentamicin. The conclusion of this study was that monotherapy with a single fluoroquinolone may be ineffective with ulcers caused by beta hemolytic strep. So as we start to look at traumatic superficial ulcers, these are typically uncomplicated ulcers that typically heal within 1 week if given the correct medications. With traumatic superficial ulcers, these usually do not penetrate further than the epithelium, and owners will frequently see the injury to the patient. So let's talk about a clinical case. Rascal was a 3-year-old male boxer. The owner's 5-year-old son shot Rascal with an airsoft gun on Christmas morning. So with Rascal, we treated him with triple antibiotic 4 times daily for a week, gave him 1 drop of atropine at the time of the examination, rechecked him in a week, and his ulcer had completely healed. Another case of a traumatic superficial corneal ulcer is with Max. Max is a 3-year-old male castrated terrier. The owner threw a set of keys across the room. Max jumped up and the keys hit him in the eye. As you can see from this photo, you can see where the key struck Max in the cornea and caused the gouge within the corneal stroma. We treated Max with ofloxacin 4 times daily for a week. He was given 1 drop of atropine at the time of his examination, and he was rechecked again in 1 week. At the time of his recheck, he had completely healed and had a corneal scar, and this should fade over the next 3 to 4 months. As we now talk about ulcers secondary to eyelid diseases, these are typically superficial. However, they can become complicated if there is bacterial involvement. So as we look at this case here, this dog has a melting corneal ulcer in the center of his cornea. As we examined his eyelid, we find that he had 1 distichia right at the top of his eyelid that was poking his cornea and caused this corneal ulcer. The ideal treatment for this patient would be cryoablation of the distichia. However, the owner did not want to pursue surgery at this time. So how should we proceed with this patient? We treated him with ofloxacin 4 times daily, Tobramycin 4 times daily. We used a topical lubricant 4 times daily, and doxycycline twice daily. We rechecked him again in 5 to 7 days, and his corneal ulcer has completely healed. Ectopic cilia are another abnormality that we see in regards to eyelid disease that affect the cornea. We see these as small, tiny little hairs that exit the palpebral surface of the eyelid and scratch and irritate the cornea. They usually cause corneal ulcers, and they are almost always at the 12 o'clock position on the cornea. We typically see these in bulldogs as well as Shih Tzus, as these 2 breeds have the highest risk. Surgical excision is necessary with cryoablation of the hair and hair follicle, and magnification is absolutely necessary to locate the hair and excise the hair and hair follicle effectively. We treat the corneal ulceration with triple antibiotic solution 4 times daily, oral carprofen for about 7 to 14 days for pain management, and then we recheck again in about 2 weeks. At that time, the ulcer is completely healed. In this series of photos, you'll see a variety of entropion, which is a rolling inward of the eyelid, and those hairs then contact and scratch the cornea. It's one of the biggest culprits of chronic corneal ulceration, especially in young dogs. Surgical repair of the eyelid and providing antibiotics such as triple antibiotic or ofloxacin 4 times daily is necessary in order to achieve a complete resolution. So that concludes the first module of corneal disease. Stay tuned for the second module of corneal disease, and thank you so much for watching.